My name is Khanyisile Lukele-Nyembe. I'm the Key Populations Program Officer from Eswatini. May I take this opportunity to welcome you all on this Link and Learn on the design and implementation of behavioral interventions for key populations. I think it would be best if we introduce ourselves based on our countries. We will start with colleagues from South Sudan. If you just quickly introduce yourself and what is your role, what is the role that you are currently doing, and then we'll move on to Congo, Uganda, then lastly Eswatini. Thank you. Delays in the introductions. Maybe let us move on with the program. We'll take this time and hand over to Cindy to do the welcome remarks so that just to kickstart the program for the day. Thank you.
Thank you, Kanye. Good afternoon, colleagues, and good afternoon to all of us, even the SNL, for organizing this Link and Learn session. We really appreciate your effort in organizing such for us as countries to share experience and also to share evidence-based strategies that we're implementing as countries. We really appreciate this opportunity as a country to share what we have been implementing, and we are looking forward to a very engaging meeting where we hope that as the host, you are going to benefit from what we are currently implementing as a country. And may I also highlight that as a country, our ministry decisively established a KP unit, which is responsible for the coordination of the KP program, which is within the Eswatini National AIDS Program or the control program for Eswatini. So it has really worked for us. I think as we unpack the presentation, that's where you're going to understand how we are implementing the KP program in the country. So with that, colleagues, we're looking forward to the presentation, and we are also looking forward to whatever question that you may have, and also to hear from you whatever that you are also implementing in the area that we'll be looking at today. With that, thank you so much.
Thank you, Cindy, for the opening remarks. May I kindly ask that you go through the agenda for today? We've just had the opening remarks from Cindy. She will also share the overview of Eswatini's HIV epidemic and the role of behavioral interventions. And then we will have FHI in Congo share the designing of behavioral interventions for key populations in Eswatini. We'll also have experiences in implementing these interventions by key populations, community-based organizations. And then I'm also going to share challenges that we have learned from the implementation. We are also going to have discussions after these presentations. And then lastly, we are going to have key takeaways from Congo, South Sudan, and Uganda. So this will be an interaction that we are all going to participate in. Thank you. May I hand over to Cindy?
Okay, thank you very much, Kanye, for going through the agenda. So I will kickstart the presentation. As you have seen in the agenda, we have a series of presenters, and we will be sharing a different aspect of our behavioral interventions as implemented in the country. May I just clarify, maybe people are now confused with program manager and now within the key populations. For the longest time, I've been coordinating the key population as a national coordinator in the country. It's just that currently I've been assigned to also act as a program manager. So that's why during the presentation, I'm wearing two hats. So may we continue? Next slide, please. We'll start with the background of Eswatini. We'll give a country profile. As Eswatini, for our colleagues that are from the other member states, we are situated in the southern part of Africa. We are sharing our borders with South Africa, and in the east, on the east, it's Mozambique. we just have an over 1 million population size. And from our population-based impact survey that we've just conducted in 2021, we have a high prevalence of those that are 15 years and above at 24.8%. We still believe that we are the highest in the world with this HIV prevalence, although we've managed to reduce it over years, but it's still high when we compare ourselves with other countries. Next slide, please. And in regards to the HIV incidence, based on the impact survey that we conducted, we have managed to reduce our annual incidence rate amongst those that are 15 years and above. We are coming from 2016, where we're at 1.36%, and with the current one, the last one that we conducted, we are at 0.62%. Which correspond to approximately 4,000 new infections that we expect to experience per year. And then when you look at the HIV incidence, you can see for our female or our women, when we disaggregate, you can see that we have over 1% of HIV incidence, which is still worrying for us. And when you compare the men and female, in terms of the HIV incidence, you can see that the HIV incidence is nearly 7 times among women when you compare them with male who are at 0.17. Otherwise, yes, our incidence rate is really worrying where we are. Next slide, please. And here we are sharing our cascade, where when you look at, we've disaggregated our cascade per women and also per men. And also we have the total, where when you look at the total, we are at 94% for those who are living with HIV and they're aware of their status. And we are at 97% for those that are aware of their status, and we've been able to enroll them on ART. Lastly, those that we've enrolled in ART, 96%, they are virally suppressed. But then when you look at the disaggregation by women and men, you can see that our men, they are not doing well with the first pillar. We have a gap there. But once we have managed to test them and they're aware of their status, we are able to enroll them on ART as we have reached the over 95%, and also for viral suppression. For women, I think we are doing well. So where we're having issues, it's among the men, especially with the first pillar. And then when we look at here, it's still the breakdown per age bands. If you can click the age bands, you can see that our women, yes, they start picking up the HIV prevalence from the adolescent age, and it's picking up over the years. And when you look at the 25 to 29, already the prevalence is very high. And if you can still click, but we have, when we further analyze our cascade, we can see that the women, they are always ahead of the men. And at some point when they are all age 45 to 49, they are all reaching the mark of 50%. So for both of them, though the women, they start earlier to contract the HIV, but at some point they are at the same peak level. And then the men from there upwards, our men, they are leading in terms of the HIV prevalence for the older age. Next slide, please. Since we are discussing the key population, we have tried to define who are defined as key population in the context of Eswatini. And the reason we have identified the key population, I think is for the same reason that we are all trying to address, as we know that these are groups which are increased risk of HIV, irrespective of the type of epidemic. We know as a country, we have a generalized epidemic. However, we still have contribution of the infections from the key population. And that is coming from the risk behaviors which we have identified to exist within these groups. Also, the legal, social, and structural issues, they are also contributing to the high HIV infections that we might be seeing. So in the context of Eswatini, we have identified men who have sex with men, people who are in prison and closed settings, people who inject drugs, sex workers and their clients, and we are also targeting the transgender and diverse person. So these are the groups that we have identified as key population in the country. So as we continue with the presentation, it will be in the context of these population groups that we've identified. Next slide, please. So why key populations? I think this is a question that we are all trying to answer. And we almost have the same reason for why are we focusing on key population is for the same reason that we have seen that there is high HIV burden that we've seen amongst this group, and also they are vulnerable in all settings. When you compare them to the general populations, I've already highlighted the risk that is contributing to them for us to identify them as high risk, which is beyond the behaviors, the legal, social, and also the structural issues. Also, we know because of the criminality of some of the activities, they are hard to reach with our programs that we usually plan for the general population. So we really need to find strategies to reach out to them. And as a country, we are aligning ourselves with the global target of, or the global goal of ending AIDS as a public health threat by 2030. So for us to be able to achieve that, we have decided that we really need to also target the key population and address their needs so that we are able to achieve that goal. And within our programming as an HIV response, within the health sector, the key populations are one of the pillars that are being targeted if we are to reach the goal of 2030. So what is on the side, the risk of HIV acquisition when it's compared with key populations against the general population? I think this is what we all have seen this from the UNAIDS, the guidance from UNAIDS, to show their risk when you compare them with the general population. Next slide, please. So on the landscape among our KP, they experience the social and legal issues as highlighted. There is a violence that is coming from the society, the clients, especially for sex workers, the intimate partners, and also service providers, because the report that we are getting as a country, it also highlights that even within our service provision, there are some violence that are also happening. There is also issue of stigma and discrimination from the society, from the health settings where they're supposed to be accessing the services. We also have punitive laws which are criminalizing the sex works and also the same sex, and we've quoted the laws that we have in country which are actually criminalizing them, which are forcing them to be underground or hard to reach a population. We also have police arbitrary arrest of sex workers, which often resulting in secondary violations that is coming from the police as they arrest them. And they've also reported rape that they have experienced when they are being arrested by the police. There have been some reported physical, emotional, sexual, and economical abuse, impeding access to our health HIV services. Social and legal status of KP, especially the sex workers, allow these abuses and gender-based violence to continue with impunity and is often underreported. So these are the issues that we have picked as a program over a period of time that is also contributing to the issues that we've highlighted, that is pushing them to have a poor access to our health services when we compare them to the general population. Next slide, please. So we thought we can share our key population size estimation and also the HIV prevalence when we focus on the key population. Based on the size estimation that we conducted in 2021, following the COVID, which might have affected the methods that we're using at that time, because the numbers were lower than what we had in 2011 when we conducted the first size estimation, we're able to identify about 7,100 female sex workers, because the size estimation was only targeting the female sex workers and also the MSM. So for the MSM, we are at 4,000. However, we have a range of beyond 5,000, which is based on the program data. And for the female sex workers, I think our range is the maximum is, or the upper limit, it's over 14,000 based on the reach through the key population program. So when we look at our HIV prevalence, for the MSM, we're at 21%. For our female sex workers, we're at 59%. And for the people in prison, especially the inmates, we are 33.4%. And people who inject drugs, this is self-reported data. They were not part of the integrated biobehavioral surveillance that we've conducted in the past. So we're using that data currently. We are working on conducting an IPBSS that will include all of them as highlighted here. So for the transgender, we're at 41.2%. So we thought we should also pull the sub-Saharan new infection figures that are usually shared, where we can see that as in the sub-Saharan, we know that we have the generalized epidemic. However, there are some percentages, those small, that are contributed by the different subpopulation within key population. So we thought, let us also highlight, because when we look at what is currently happening, it is what it has been observed across all sub-Saharan African countries. Next slide, please. So this is our cascade of 95-95 as we tracked it during the IPBSS, which we conducted in 2021. You can see that for our first 95, we're at 84%, so we have underperformed. And for the second 95, for those that were identified or they know their HIV status to be living with HIV, we've been able to enroll about 97%. And for the last 95, which is the viral suppression, we are at 94%. Next slide, please. Unfortunately, this is limited to the two populations. We hope with the next IPBS that we are working on conducting, we will be having the different cascade for all of them. And in terms of the overview of the development process of the behavioral change materials that we are implementing in country to try and address the gaps that I've already highlighted, for us to be able to identify the gaps, it includes the use of the IPBSS, the Interbiobehavioral Surveillance Survey that we usually conduct. So during that, we usually put some questions that we're able to understand the behaviors that are out there. We also have program assessments, like we've just concluded the size estimation and mapping, where we also have some questions that are tracking the behaviors. Also, we're also informed by the program data as we look at how we're performing quarterly or annually, and also the feedback mechanism as we have the community-led monitoring. So all those, and also the peer education program is also providing information on what is actually happening on the ground. And we have national guidelines and frameworks which have approaches that we are supposed to implement as a country. We are engaging the stakeholder, which is our partners that are supporting the implementation for budget, and also participatory, where we always have everyone that is engaged during the process of planning, whether we're developing a document or it's planning of designing the programs itself. So we are also working as a team to also create a social behavior change communication documents, and we pre-test them through the partners. We implement through partners. We are monitoring and reporting through the implementing partners whose reports are feeding at national level. Next slide, please. So this is just to share what we're able to pick, and we've already included in our guidelines as contributing behaviors that needs to be addressed by the interventions that we have planned. So you can see that we have already packaged the individual risk. which we are supposed to address as in group session or in one-on-one. I think the colleagues are going to unpack that. And at the societal level, we also know that there are issues such as the stigma and discrimination. We have issues of social norms. We also have family expectations, which are also affecting the behaviors of the KP. And then the structural risk, which are happening within our society. So all these are, as a program, we are addressing. Next slide, please. So this is a slide that is showing, I think it's still highlighting the issues that I've already highlighted in the previous slide, which are the risk behaviors that are exposing our key population. We just pull these two a PowerPoint slide, which were coming from the IPPSS, where we're tracking the usage of the condom and water-based lubricants. The first slide is speaking to the behaviors when it comes to condom usage and water-based lubricant of sex workers, comparing it to the 2011 and 2021. The blue is 2021 and the red is 2011. So over the years between these two IPPS, for the sex workers, there's been an increase in the use of a condom in the past 6 months with their partner. I think we are at 50%, and in 2011, we're 32%. However, what is worrying for us, it was this 60% where they've reported that 60% of them reported that their partners, their clients, they demand unprotected sex. So that is worrying, especially with us implementing the usage of condom and lubricants during their sexual activities. But then 60% they've reported that they've engaged in unprotected sex because their clients, they were demanding that, and that they promised to pay more for that. And then for the MSM, which is the next slide, and this one includes also the transgender, you can see that the blue ones is still the 2021. Those that were using condom, there's been an increase ever since the 2011, where it was 48%, 60% here. So you can tell with all the interventions that we're implementing that there's still a gap. So those are the things that we are continuously tracking so that we can close the gap and see what strategies can we implement. And next slide, please. So this slide is showing our policy documents that are guiding the linkages to behavioral interventions. As I've already mentioned, that we have our partners. Through our partners, we have the peer education program that is able to engage at community level. And we have this guiding document that helps to guide how do we then link those that are at risk to the intervention. We have developed a core package of HIV prevention guideline for implementers, which has defined the minimum packages for the different key population groups. We also have a high-risk reduction communication module, which is used in engaging and assisting in the client to identify the risk factors and then the linkage. And we also have the HIV prevention day referral and linkage job aid, which is usually used by our HTS. After client has tested negative, it helps them to engage the client and identify if they're at risk. If they're at risk, they're then offered the prevention package, and they are linked to whatever prevention package they wish to use. And there is also the HTS risk assessment tool, which is embedded within the HTS module. And we have Your Journey, which helping our ambassadors, the prevention ambassadors, to help our clients to choose a method that will work for them. The last one is the HIV linkage case management SOP, which is also guiding the implementation in the health facilities. Next slide, please. This is just a slide that is showing how we are coordinating the implementation of the intervention in the country. As I've highlighted at the beginning, that we have the Ministry of Health through Eswatini National AIDS Program, which is responsible, a unit responsible for coordination of the implementation of the KP program in country. And what we have done as a country, because we have a donor funding coming from Global Fund and also from PEFA through USAID, we have divided the country to avoid duplication of efforts based on the donors. So we have, our country administratively is divided into what we call Tinkundla or constituencies. There are 59. So we've tried to identify where we have existence of KP, and then we have divided those constituencies into the two donors based on the budget from the donors. So for implementing partners, we have FHI 360 under PEFA. We also have Congo, which is using Help Plus for Men under the Global Fund. And from there, the actual implementation is being led by the community-based organization from MSM, from sex worker, a network, and then from the transgender. We also have our PWIT. I think we have about 4 of those networks that are actually in the implementation at ground level. We don't have these implementing partners like the FHI and the Congo Help Plus being the Congo being the ones that are implementing at community. We are now using the community leading the implementation in the country. Then next slide, please. So I think I'm nearing the end of the presentation. So this is the multi-sectoral approach that we're using to conduct among the healthcare workers. I think you remember that in one of the slides I've highlighted the structural barriers. So we are also addressing those within the Ministry of Health. We are trying to address the issue of the stigma in the health setting, that is the facilities. We are also targeting the police, as we've highlighted that they're also experiencing abuse and also violence from the police. So we've engaged them in trying to address such. And then at community level, where we have the civil society, we are also engaging the different structures to address that. So these are the documents that we are showing here, which are assisting in addressing. The first one is a training manual for healthcare workers, which actually highlight their risk, which also highlight their needs. And then we have packages that they are supposed to be implementing when they come in contact with the key population. So for healthcare workers, we are doing 1-day sensitization and also comprehensive trainings, which can take up to 5 days. And then we also have what we have developed. It's another training manual that we've developed for police. They are also using it in their academy, and we are also training them as Minister of Health from time to time with the CPOs. We have our ambassadors that are always there posing as ambassadors and sharing their experiences, sharing their challenges, sharing their needs. And then the last one, it's a peer educators manual, which is used to train the peer educators as they engage with their peers. Next slide. So I think this is my last slide where it is speaking to the ambassadors, which I've just highlighted, who are engaged, whether we're training police, we're training the healthcare workers, and also at the community level, when we are dealing with the different gatekeepers in the different communities. So for stigma reduction in health facilities, we're targeting the pre-service, that is the universities where our nurses are largely trained, and also in service, we are targeting those that are already in the facilities. For the police training and sensitization, we are training all levels from the executive up to the lowest level, which is the police station. So this is what as a country we're doing to address the attitude towards our key population, which at times is contributing to the behaviors which are putting them at risk, especially when it comes to access of the services, whether within health and also even addressing some issues where they need the police. So we are engaging, it's beyond these two ministries. We also have the justice. We also have other ministries that are where they are like the Home Affairs, where they are likely to also experience some attitude from those workers when they go there for whatever service they might need. I think, next slide, please. I think this was my last slide. Thank you so much. I think I will hand over back to Kanye, our program director. Thank you.
Thank you so much, Cindy, for the wonderful presentation. May I remind colleagues on the call to kindly register on the chat and be vigilant if there is any poll that needs to be attended to, so that they are able to attend to. And please, if you have any questions, may you kindly jot them down in case you forget. We are going to have a discussion at the end of these presentations. At this juncture, may I allow Peggy Sitolia to present on the designing of behavioral interventions for key populations. Thank you. Over to you, Peggy.
Thank you, Chair. And please confirm if you're able to hear me well, because I'm using earphones. So I just want to be sure if I am audible.
Yes, you are, Peggy.
Okay, thanks. So, colleagues, just a second. So, colleagues, I'm going to take over from what Cindy Mate was presenting from the national level in terms of our, coordination of the KP program. So mine will be, talking about, part of the design of the SBCC material from, a partner's perspective who is supporting the Ministry of Health, because the ministry is coordinating and providing leadership overall and working with us as partners in terms of, providing that support. So I'll be talking about our experience from FHI 360 as one of the partners that is supporting the ministry. And just also to highlight that we are working with other partners, as Cindy also has already highlighted. We are working with other partners on the ground. So our partners will be sharing their experiences later. And also just to highlight that we are working with, yes, community-based partners, but we also work with another partner, which is Kango, who is implementing through another community-based partner. So we have that partnership with Kango, who is also which is also a partner who supports the Ministry of Health. So, and our program, the Key Populations Program, is aligned such that everything is from all the supporting partners is aligned in terms of implementation. So everything is implemented, equally or similarly. So can we move to the next slide as I go through the presentation? So this slide shows an overview of our coverage in terms of where we deliver the SBCC materials. So we are partly working in the community, mostly working actually in the communities. So we do outreach to reach key populations wherever they are. So our partners then are allocated geographical hotspots to target to make sure that there are no overlaps or duplication of efforts. So we have partners under FHI 360 who are implementing in different hotspots under different Tinkundla being constituencies that demarcates the country. And at the same time, we are also working in what we call community centers locally, but these are drop-in centers for key populations. So we also provide the SBCC through those centers or through those DICs. Next slide, please. So in terms of the process of designing the SBCC, so our role is really mainly to, work with the partners to design and also support them to implement this SBCC. And in terms of the process, we participate in the development of the National Communication and Behavioral Change documents, as Cindy highlighted from the MOH side earlier. So we become part of that as a supporting partner. But we also engage partners in developing specific SBCC materials. So we do work with Global Fund as another partner, as I highlighted earlier, who implements through Kango and Helpless for Men. And we also work with the KP-led organizations, as mentioned earlier. We then pretest these material among the relevant populations and adjust as needed. We then implement these SBCC materials through the KP-led organization. And from our end, we make sure that we support training and refresher trainings of the outreach workers of these organizations who are implementing. We also monitor implementations, the implementation of the SBCC materials, for quality purposes. And we sometimes have, make sure that we want to give the partners some feedback to improve where there is a need to improve. We then report on the outcomes. And there's also M&E, where we look at outcome and impact, and our impact is mostly indicated through the IBBSS reports that we conduct, periodically. But we also look at some outcomes through our program reports. Next slide, please. So in terms of the type of SBCC materials that are being developed, sorry for the title, it's supposed to be SBCC. So there is, we design a online-based IEC material. We also design, paper-based material. So I will not talk on length about the online-based, because one of our partners later will be talking more on that one in terms of the process of design and their experience of implementing it. But I will talk to the paper-based IEC material. So for that one, we develop the material. We have a committee which include MOH and the partners that is responsible for development of the specific IEC based on the gap, like Cindy mentioned earlier. We look at the gap and then we design through this committee. We then pretest among the target population, and then we print and distribute widely. And it's then implemented through outreach workers. And at the end of the day, we look forward to this to translate into, people accessing services, or over time we can be able to, see some, behavior change. Next slide, please. So this is an overview of, some highlights of what we do in terms of designing our online programming for SBCC. So basically we have the partner Rocofop will talk more on the process, but we do have again a committee for designing these kind of materials for going online, and they are posted on different social media platforms. And sometimes we do different, interventions to make sure that it reaches people widely, including boosting paid adverts and stuff. Rokofo will talk more about that. But what I also want to highlight is then people are then be able to be linked through this on the left side of the slide, through this website where they are able to book for services. So they are then booked for services online, and then they can access services, or they can interact with online outreach workers and ask questions and engage and all that. Next slide, please. So again, this is our print media material. We are also showing example of some of the materials that we design. Most of them are individual based. That is, an outreach worker, when they are going out there doing outreach, they can, engage individuals that they meet and give some of the material to individuals, but some of them are are small group based. For instance, we design what we call desktop desktop flip charts, where someone can use, that is, an outreach worker can use to conduct small group discussions with key populations and put it on a desk or wherever they put it, and then go through and engage them in terms, with discussions. It includes photos and all that. I'll share that on the chat box. So these kind of materials are also designed per population, based on their needs. What we are seeing here is one for sex workers, the other one is for MSM. So we have also been working with Tango and MOH to design others for transgender and PWID, because those population do not have this kind of small group discussion material. So we're working on designing that. I think we are at a stage of them being printed now. And then again, the materials cover topics throughout the HIV cascade. Next slide, please. So this is another example of a print media material. This is PrEP and event-driven PrEP. So again, the engagement was the same process in terms of developing it. So again, we have different kind of this material. Others are from are for service providers, while others are for PrEP clients, that is, individual key populations or any other populations clients. Next slide, please. So in terms of demand creation or using these materials that are being designed, so key population outreach workers are trained, and that is what we do as a partner to support that, to make sure we are designing, and also to support to make sure there is quality in the training. So they are trained to use the IEC material. Outreach workers are then trained to mobilize, and also communication skills, because then it becomes very important for outreach workers, for instance, to have the skills to communicate this material. It includes micro-planning and motivational interviewing. They are also trained on mobilizing skills, including SNS, which is social network strategies. They mobilize at hotspots, which are identified through hotspot mapping, and then they conduct session and provide risk assessment among key populations. They then, when it comes to the M&E part, they then enter the KP, provided these SBCC sessions in the HIS2, and the sessions cover, and also there's kind of sections that are covered. They provide HIV prevention services, which is including condoms and lubricants, and also HIV test kits at community level. And also they refer to services. Again, this is the kind of the, IEC material that has been designed and developed, according, as I've mentioned, that they cover the spectrum of the HIV cascade. This example that we're seeing here is about use equals to you, which then they teach about or educate about, and also PrEP and also family planning. So it's a wide range in the cascade of these topics that are covered. Next slide, please. This is the last slide. So basically, there are then two kind of sessions for communication. I think I've highlighted earlier. They include communication in a small group, which includes 2 to 20 individuals, to get them to adopt low risk behavior or any HIV prevention care and treatment services. And the other one is individual meetings. That is one-on-one engagements, where again they engage individuals and educate or inform them to adopt low risk behaviors. So this is the end of my presentation. Over to you, Chair.
Thank you, Peggy, for the presentation. I think at this time, we hand over to Msizi, who will be doing the presentation on Congo. Thank you. Msizi, over to you.
Thank you so much, the program director. I'll be presenting on behalf of the Global Fund support in country. And my name is Msizi Mkhabela. I'm with Help Plus for Men. So our presentation, most portions have been covered through the presentations that have been that we have appreciated. So I'll start our presentation with the program design, or our approach to program design. So as we are implementing a program that is supported by the Global Fund, our approach is based on national gaps that is derived from existing needs and support from domestic funding, as well as gaps that emanate from other funding sources, such as PEPFAR. Now, the Ministry of Health, as said, allocates geographic implementation areas in so that PEPFAR programs and the Global Fund programs can work together to improve the impact and build a good synergy. Global Fund interventions are led by CANGO. CANGO is a coordinating assembly of civil society organizations that is acting as prime to the Global Fund programs. So CANGO implements community programs through a competitive bid from community-based organizations based on strengths and peer relevance. So our programming is based on a participatory approach where the MOH uses community-led data to inform the development of standard package of services for the program. Then we'll develop a standardized curriculum, as Peggy alluded earlier, through guides and consultations from the community organizations and the community at large. And then CANGO, through the SRs, uses a standardized package of to design community interventions that involve behavioral, biomedical, and structural issues. So our programs are also based on evidence, and that is supported by the national documents and strategic documents that FHI is also supporting on, which is the IPBSS study, the rapid coverage survey, size estimation, and hotspot mapping. Program interventions are also aimed at reaching most at risk and hard to reach population groups through a standardized risk assessment questionnaire that clearly delineates or selects the most vulnerable population. The program uses outreach workers that are also selected from the SRs through a peer-led process where MSMs will be implementing interventions or leading interventions to reach MSMs, sex workers, leading interventions to reach sex workers. The program structure is also based on the 95-95 approach or target, where clients are reached and cascaded within the program interventions until they reach that continuum of services with a goal to ending AIDS. For our behavioral intervention, our approach is rooted from the Health Plus for Men level or SR level. We use an approach that is based on our theory of change that aims to create an enabling environment for the well-being of key and vulnerable population. Our approach targets the behavioral transformation at individual level, institutional level, and national level. Some of the modalities that we use are social network strategies, where we work with a risk network referrals, trying to reach more populations through a snowballing approach, enhanced PA outreach approaches and activations that are specific to the particular population, where we have activations or campaigns such as the Men on Heels, cultural days, and the Miss Trans pageants. Then we also do peer-based mobilization, where we engage peer energizers, PrEP ambassadors, to try and improve reaching various networks within our population. Then we also use an ambassador strategy, which is mainly used towards gender transformation and also PrEP. So these ambassadors are quite handy and useful in conveying first-hand information to our target population and helping them to see the gaps in service delivery. Then we also do index testing, which is quite more clinical. FHI 360 leads the biomedical interventions that are being provided within the programs, the entire KP program. So it's one clinical partner that supports the entire KP program, regardless of the funding source. Then we are also coordinating safe spaces, where we are trying to create more behavior change or hold more sessions on behavior change interventions. FHI has already alluded on this particular one. Then we also use social media or online platforms through the support from the Rock of Hope and the EPIC program. We get messaging that we are able to post to various groups. There's also some social media mappings that are being done that helps us a lot to reach our population. We also conduct webinars and also infographic material that is used to capture our target population. We also use small groups and focus group discussions to deliver health talks and do engagements that lead to service delivery through a standardized curriculum. We also do trainings, which is now at institutional level, where we try to reach more service providers or through a multi-stakeholder approach, where we do sensitization on transformation of gender and harmful norms and practices to ensure that as much as we are providing a behavior change at individual level through these group discussions, the institutions such as healthcare workers or police service are also sensitized, and also other essential service providers. Then these are followed by sensitization at national level, where we just do advocacy campaigns across the country, including your Culture Day, your Pride celebrations. We also try to push and sensitize the public towards law reform and also a creation of an enabling environment for our population. Our evaluation of these strategies are basically based on the studies that we then conduct as a country, where the IPBSS study will help us see improvement from the different biobehavioral, biomedical, and structural intervention. If there are changes or improvement, or if we are getting worse, then we know which areas we need to focus on. Then we also rely on community-led monitoring reports and data that also helps us to make sure that our services are directed to the right population. They are of the same standard and quality to ensure that we achieve an environment that is enabling for the well-being of our target population. I think I'll end here and hand over to Program Director, Kanye.
I'll be sharing the experience in implementing behavioral interventions for KP in Eswatini, particularly FSWs. Okay, the interventions that we have, we do the approaches through materials, which is IEC materials such as pamphlet, discussion guide, which is used by the outreach workers. Then we also have one-on-one discussions whereby we use a risk assessment tool. Also, we use visuals, which are videos. Maybe they can show about PrEP, they can show about STIs, and so forth. Also, advocacy. Also, we have a Facebook page, media. Next, please. Can you scroll? Okay, our targeted population and our coverage, we are targeting sex workers. When we mean sex workers, we mean comprehensive sex workers. Then also we have the minors who engage in sex who are under the AGWI. We are not able to call them sex workers because they are below 18. Then also we target children of KPs under the OVC program. Also we target the client of sex workers. When it comes to the coverage, we're in the 4 regions and we do this at a hotspot level and home-based settings. Next slide, please. How do we plan and deliver SBCC? We have some structures that we have when we want to develop a certain message or any material that can be used by sex workers. We reach them through the super groups, also through their hotspot sessions to share what we want to do. Then they have to put their views out there. Then we have to act on it again, take back the material for test. Then if they agree, it will be there. Also, it goes through the different structures when it comes to FHI 360. Also, there is a committee that used to review the messaging. And when it comes to the advocacy work, it has to go through the different clusters that we have, also the consortiums. When it comes to the governance, it had to be reviewed by the board members. Also, we have the SBCC material development. What it entails, what we have is that this can be evidenced through the meeting minutes that we have and the processes that we do. Also, involvement of the KP in the design and testing of the interventions. Then we also have the FGDs that are conducted to validate information, testing of the materials, and asking beneficiary on the language that they need to be used. Next slide, please. Monitoring and evaluation activities for SBCC. Compare the effectiveness of the program data with the objective of the program. Look into the achievement of the program goals. also community reach feeding into the program indicators through through theory change, have an input and also output goals which can be short and long term. Next slide, please. Hi, Kanye.
Thank you, Lungile, for the presentation.
Thank you.
Colleagues, Voice of Our Voices is one of the KP-led organization that is implementing the behavioral interventions for sex workers in Eswatini. Transwati is also a KP-led organization implementing behavioral interventions for transgender people in Eswatini. Over to you, Transwati.
Thank you for the introductions, Kanye. Can we please proceed to the next slide? Okay, so my name is Tepo Melvin Dlamini, and I'll be making the presentation on behalf of what Transwati is doing in regard to the social behavioral change communication. So interventions that are done at Transwati is the conducting of health talks, which is to encourage trans diverse people to access health services in the KP mobile clinics and community centers to create visibility. Conducting of sensitizations, which is creating an enabling environment free from stigma and discrimination through awareness raising on trans issues and barriers in accessing healthcare services. And then community empowerment activities, which is a platform to disseminate information to trans diverse community members on topics of interest to assist in building capacity. We also do skills development, which is equipping trans diverse community members with knowledge and tools to become entrepreneurs, to assist them in becoming financially independent, as well as addressing the alarming concern of employment opportunities, the lack of employment opportunities. The skills development also addresses the component of economic strengthening. The next slide, please. Okay, the target audience that Transwati works with is the trans diverse people, which is inclusive of transgender women, men, gender non-conforming people, as well as intersex people. So Transwati reaches the trans diverse people in 3 regions, which is Manzini, Shiselweni, and Lubombo. Transwati also reaches service providers, namely healthcare workers, uniformed officers, legislators, ministries, and media houses. In addition, Transwati also engages parents, religious leaders, and community members. Transwati is able to reach the different networks through snowballing, contact listing, engaging other implementing partners, embassies, and through community consultations. The next slide, please. Okay, so the data sources of the data sources are as follows: attendance registers, hotspot mapping, the IBBSS, DHIS2 tracker, capture, and success stories as well. So the trans diverse community members have a platform to give feedback in regards to when we have the community empowerment sessions and health talks. So this is just to understand the experiences they encounter when accessing healthcare services within the different modalities of the drop-in centers as well as the mobile clinics. And then trans diverse people leading implementation of activities are in decision-making positions in the movement of the trans diverse people. And then the activities completed are documented, and at the end of the year, we always document it through an annual report. So I think that is the end of my presentation. I would hand back over to the program director. Thank you.
Thank you, Transwati, for your presentation. May we move on to the Rock of Hope? Over to you, FP.
Good afternoon, colleagues. I'm Eswatini from the Rock of Hope. May we proceed on another slide? Thank you, Kanye. As the Rock of Hope, we are going online. I think Peggy just said much on going online on his presentation. So I'll be going through the process of content creation. We have a going online content creation committee for our KPs and CPOs representatives, where we plan the messages and we send to MOH and the USA to approve those messages. Then the committee meets monthly and creates going online messages and share it with USA and MOH. Then after reviewing, a graphic designer then develops the social media artworks or posters and sent back to the committee for reviews. After the committee review, then the posters are shared back to MOH and USA representatives for a final review. Then after the final review, then we use the demand creation across all social media platforms where we post on our social media platforms, which are Twitter, Facebook, Instagram, Tinder, and Grindr. We also use WhatsApp as our communication platform. Another slide, please. The monthly artworks that promotes together realizing Ubuntu Eswatini the true services and are posted on Facebook, Twitter, Instagram, as I said, and WhatsApp. Then a creation of a monthly advert is done using one of the posters developed on that month. We also post these posters every month so that we can reach more clients on social media pages. Then when posting, we also provide a link and a WhatsApp number for clients who want to book their appointments. Clients are able to book their own appointments if they have problems or issues on booking their appointments. Then we then assist using the WhatsApp number, or then they call. Then we take their details. Then we do their appointments. Clients then send inboxes, WhatsApp chats, asking about our services. Then we provide those answers about our services. Then they then book their appointments. Clients who are interested on our services are then assisted on making appointments and then visit through centers. And then clients who miss their appointments are followed up and rescheduled for another day when they are free to visit our true centers. Sometimes you find that some clients maybe they book their appointments maybe on, let me say, on Tuesday, while they'll be at work. Maybe they have some issues with their bosses. Then we can reschedule that appointment maybe for Friday or wherever they are, whenever they are ready to honor that appointment. So, and then after that, we follow up on those clients to check if they did get the services. If they didn't get those services, then we reschedule an appointment for another day where maybe those services are available for them. Another slide, please. This just shows one of our posted poster, which we posted on February. As we can see, we have 37.8K reach. We have 634 content interactions, and we have followers lifetime, which is 3.9K. Then we have link clicks, 484, which are maybe clients who are using the links, who are pressing the links on Facebook, where we post it on the poster. So they click the links, then we see that we have 484. Then we do this every month, and we then get messages on WhatsApp, on Facebook, then we have clients to book their appointments. I think this is my last slide. Okay.
Thank you, FP, for the presentation. So may I quickly go through the challenges and learning from the implementation? May you go to the next slide, please? So the challenges that we have, I think everyone would agree that implementing behavior change interventions is a bit hard because you communicate and expect people to change or modify that behavior, but not everyone will be converted or change that behavior. So we do get people who will change the behavior, but we also get people who do not change that behavior. And it is also not easy to measure the extent of how these interventions translate to behavior change and contribute to positive outcomes. We also have limitations with funding for developing and printing, since most of the support that we have, I think every funder now wants to support interventions that have immediate impact. So with behavior change interventions, it's a bit tricky and difficult for partners to measure the impact because it takes a long time for us to be able to see that behavior. So where beneficiaries have to complete a series of sessions, sometimes they do not come back. They might come back once, but then when they're supposed to come back again, then it becomes a challenge. And the other challenge is that some of the key populations are highly mobile. So it is very difficult for them to come back for those services. Our partners, as they have mentioned, they conduct small group discussions, which seem to be working because they help us in terms of engaging and discussing with key populations. So these small group discussions are conducted at community level and they are live. So in a way, it also helps us in terms of reaching key populations. However, you find that partners would lack the resources to gather in a common place and sit for a session, because I mean, sitting for a session, you find that people have other priorities rather than to sit for a session. So they might prioritize other things than doing a session. So in terms of going online, messaging can reach a wide audience, but there's always a need to post messaging through paid social media adverts or through paid influencers, which sometimes is a challenge. And also you find that clients would also book for a session, but in terms of showing up for that appointment that they've booked is also a challenge. So I think those are some of the challenges that we have. Next slide. So thank you so much, colleagues. So this is at this juncture will allow for questions from those who have questions for this session. I will pause here for now and allow for questions. I think we have one question online, which says why the prevalence is also high amongst prisoners. Highlight what is there.
Yes, colleagues, I'm failing to raise my hand.
Oh, okay.
I don't know. This is Dr. Mdiope from Uganda. And I had a question. Can I go on?
Yes, please go ahead.
Thank you. And thank you for the beautiful presentations, giving me an insight of the program. I'll cut time short. Just on the last thing that you looked at, the challenges, I know they are doing a good work. How is the monitoring of the messages and the behavior interventions done, since it's very difficult to measure the outputs or outcomes? Is there any effort to do a continuous M&E activity or tracking of the activities that are being implemented in Eswatini? Thank you so much. Over.
Thank you for that question. Do we have any other questions? So that we take at least 3 questions before we can respond. Okay, I can see, is it Tande? You have your hand up. May we give you this opportunity to ask your question?
Oh, thank you very much. I guess you all can hear me clearly. Am I clear, everyone?
Yes, you are.
Thank you. Thank you very much for the presentation. Most all the presenters from a specific country, and we have learned a lot from your approaches and way forward when it comes to this behavior change and all this. I've seen one of the methodology or the approaches you use is the social media and the IEC materials that have really worked for the context of the country that you're in. And I just wanted to understand how you got to get this so easy in reference to the country's laws and constitution, so as it can be able to flow so much more easy in that way that you put it. Because in the context of my country, it's kind of, some key populations are kind of criminalized. They only recognize a few. For example, the sex workers or maybe people who use and inject drugs. But some key populations such as the LGBTQI community are criminalized, and of course they exist. When it comes to the HIV programming, of course they need to be part of to ensure that we see the total eradication of the HIV in the country. So I don't know what approaches you really used in regards to beat the fact that some
I don't know if it's us. I think we have lost Tande, but I hope he was done with his questions. But maybe let us respond. If we don't, seemingly there are no other hands, may we respond to these 3 questions?
Okay, thank you so much for the questions. I think I'll start, otherwise the whole team is going to also share their own responses to the question. First of all, may I start with the question that has been put on the chat, which is asking about the HIV prevalence being high in our prisons. Part of the reasons, yes, we know from the biobehavioral studies that we've conducted that there is some sex that is happening within the prison based on what we got as we're engaging with them through that survey. However, in our prison, what I can say, we are not providing the prevention services within. They only access the services on their discharge. That is when they are leaving those facilities. 2, we know we as prisoners, when they're incarcerated, some of them, they come or they are admitted in the prison settings already HIV infected, and we know surveys, it's a snapshot of those that have just been infected and the long-term infections. So for prisoners to be staying over time, those who have come with the infection, it means that whenever we randomly select, we are likely to also pick them, and that is also increasing the HIV prevalence. So it's only now that we're conducting the new biobehavioral surveillance among the prisoners where we'll be tracking the new infections, the recent infections. So it's going to tell us those that were able to pick the infection in the past year, so that we can establish if it's new or it's an old infection. Otherwise, in the first one, It was just the snapshot of the HIV prevalence. So it's not easy to determine whether it's because they came with it or they also contracted it within the prison. So what I can say is the contribution of the two factors: coming already infected, it's likely that they're picking the infection within, since we are not providing any prevention method within the correctional. However, with the new IPBS, I think it's going to tell us what exactly is happening within there. And then the other one, it was around the reach. I mean, sorry, the impact of our behavioral interventions. I think what you've already shared is what we are also a challenge with, especially because I think Kanye highlighted that it is also a challenge that we are not able to link the intervention to the immediate results. As we know that behavior change, it takes a long time. So what we are doing is the implementation, and the implementation, and you expect the results to see them over time. And when you look at the surveys, which is the only source which is actually giving us the true picture of the implementation that we've been putting on the ground, it's when we're doing the surveys. That's where we are able to get the information. Otherwise, from time to time during programming, we are able to pick up the number that we have reached, if we are distributing any material, the number that we've distributed, and also the availability and access to such material. Otherwise, to see if that has had an effect on the behavior change, it is over the surveys. So that's where we always gather the information to see how big is the gap. Like I was showing those slides where you can tell that when you compare even these IPBSs, they're telling us that at some point we're doing well in terms of the demand creation because of our percentages were high. However, when we conducted the recent one in 2021, there is a reduction in percentages of those, or proportion of those that were still had a knowledge in some areas, some even the behavior change. So that is telling us, for us to understand what is happening, we're still relying mostly on the survey. And then the last one was on
the one on the legal aspect.
Oh, okay. I think in my presentation, I did share that we also have punitive laws where there is criminalization of the same sex and also the sex workers. What we have done, I think it has worked well for us, as I've shared also in my presentation, that we are engaging the police, where we're engaging them from bottom, which is the lowest level of service provision, that is the police station, up to the executive, where we are training them. Actually, we use the IPBS report to highlight the HIV prevalence coming from the health sector, and what has the implication if we are doing nothing with such a high HIV prevalence among our key population, and also the interaction of the key population with the general population. What does that mean? So that they can understand where we are coming from as a Minister of Health. And other things that we also highlighting is the behaviors, which we are picking from the IPBSs, and we engage with them so that they understand what does it mean for them to be confiscating or arresting the KPs based on carrying a condom or a lubricant, because that's what they used to do. And also for arresting those that will be accessing the mobile services, because at first when we started providing the mobile services, because we use these flexi hours, which are late hours where all facilities are closed at night. So they used to also arrest whenever they see such mobile units. But when we engage, then they then understood for us to reach their, like the sex workers, we really needed to be working during those hours. So those are the things that has really helped the country to reach them. That is sharing the evidence. We are also using them as ambassadors whenever we engage these police, to also share their experiences, also share their needs, and also the support that is coming from Ministry of Health. And then they highlight what kind of support they will really wish to receive. And we've also engaged our parliamentarians, which are also engaged on the status of where are we as a country in terms of the HIV prevalence and other behaviors, that as much as we are targeting the general population, if we are doing nothing on targeting the key population, it might also reverse all the gains that we see in the general population. So that has really helped. The laws are still there. We are still working on reversing all those laws that are actually criminalizing or are a hindrance in terms of the uptake of the services from our side. So the advocacy using the evidence base, it has really helped the country in terms of the improvement in the uptake and also the accessibility to our services. I think I'll stop there. Maybe other colleagues would like to add.
Okay, I think just to add to what Cindy said, in terms of the IEC material and using social media, when we develop these materials, we develop them specifically for key populations, and we use key populations to distribute these materials to other key populations. So the target is not the general population, so it is key populations, and we try to make sure that it reaches key populations through key populations. And the other thing is that even with social media, engaging people on social media, we use platforms that we use are normally used by key populations. We don't just post for the general public. We only post where we know we are going to reach key populations. I don't know if Tande would want to continue with the question before we move on to the other questions on the chat. Tande, would you like to continue with your question?
Thank you very much for the opportunity once again. I guess the first presenter already answered a lot of the questions in regards to the laws and the constitution that criminalize some key population, and of course, I know the approaches of you approaching the law enforcement bodies from the lowest to the highest. It's much more effective, yes, but there's a problem of public acceptance that really makes it a bit hard for some context. Like, for example, Tande is from, I'm from South Sudan, and the context here is a little bit strict and hard, whereby our organization, we have to function under low key functioning. And of course, we get some help a little bit from a few partners who can help us run some of the programmings for the key population. Acceptance is still a problem with the local community because they believe that we don't exist. And of course, approaching some of the government organs that deal with HIV prevention, we're able to convince already. And of course, slowly by slowly, we're getting involved with the HIV programming. And the other part of the key population that were not so much engaged in their programming is the people who use and inject drugs. This is also key KP. I just wanted to understand what approaches did you use to ensure that you come up with appropriate engagement of these people who use and inject drugs, because they really play a mega role in this whole HIV fight. I don't know how you did that. Otherwise, thank you very much for the opportunity. Once again, my name is Tande from South Sudan.
Thank you, Tande, for the question. May I give it to my colleagues to respond to this questions? I think Msizi will answer the one on people who inject drugs. I think Peggy would also come in terms of some of the questions that were asked. May I hand over to Peggy, then Msizi?
Okay, I think the main question was the one on the people who inject drugs. So I can share and Msizi would share their experience, but really it's also it has been about, you know, considering their networks. What we are doing is really to try and follow their networks. And currently they do not have an organization. I think it's a bit easier with the other populations here in Eswatini because there are community-based organizations for, say, sex workers. We have one. There are several for that include men who have sex with men and other LGBTQI people. We have also Transwati for transgender population, but for PWID, we don't have a population. So besides, providing services to them through the, social networks, strategies that we are using for providing services, but we are also trying to strengthen their network. So there is engagement for the PWIDs, even though they don't have an organization, at least for the networks in all, interventions from Ministry of Health level to program level. So that is trying to strengthen the networks that we currently know about them. But it's an ongoing process because, yes, we know the networks that we know, but we are still trying, doing as much in terms of our interventions to reach more PWIDs that we might have not met. But it's really following their social networks, but then also making sure that we strengthen the networks.
Thank you so much, Program Director. Yeah, I think Peggy has just actually mentioned it. We're leveraging a lot on the social networks. We are using outreach workers that are ex-drug users that have knowledge and relations with multiple hotspots in their catchment areas. That helps us reach their injecting partners. So we also do some activations that are tailored to them, such that we try to remove the whole concept from an HIV-focused engagement, but sort of like an empowerment, a community empowerment, trying to involve some social issues, gender-based violence, choosing different angles that would also interest them. And also the part on economic strengthening. We are also trying to seek out support from different areas to beef this intervention or this engagement such that it doesn't only focus on the HIV prevention part, but it also offers the much needed support. For instance, your NIGLI exchange program, which is the country is still working on, your opioid substitution, which is OST, which are issues that they are actually in need. So while the country is still trying to speed up or get into pace with those intervention, we just try to make them more social while making sure that we touch base on these dangerous behaviors to help them and support them such that they don't get infected with HIV. Otherwise, it's quite a risky business, especially with the social networks. In-country drug use is a serious offense, and these networks are quite closed. So sometimes it requires that our outreach workers would need to gain trust from their from that particular hotspot. Then they find themselves getting in touch with our dangerous substances to a point of almost relapsing. But we try to support and ensure that we place the safety and the well-being of our outreach staff and ensure that they are protected and don't succumb to any relapse. Thank you.
Thank you, Msizi. May I ask Lungile to answer the one on how are you helping the sex workers to always use protection when the client asks for unprotected sex? Lungile, may you take that one? Thank you.
Thank you very much, colleagues, and thank you, Chairperson. For that, how do we really ensure that sex workers are able to use condom? Mostly, we are connecting the sessions through the on-site, which are the hotspot, and ensuring that we are able to also build their capacities through giving them knowledge that how much wealth is life. We know we want money, but if you will hunt money without being healthy, you cannot even get the money that you are hunting. So we also have them the session guide that the outreach workers use to their peers to ensure that if they have any issues, they have to make sure that they get in line on what they have been educated on. When it comes to that, the condoms, we also strengthen that different methods are being used to ensure that you put the condom, even you can dodge the client. For example, if a client is asking that, can we have it without condom? Then we skilled you, how can you put the condom with your own mouth without the client understanding that you are putting a condom. So there are those techniques that we enforce and strengthen to our clients, and to ensure that also when they take it out, the client cannot understand what was happening, but only the negotiation fee that has to come forward as it is. Thank you.
Thank you, Lungile. I think we have one last question on the chat, which says managing KP programs are called across multiple settings present unique challenges in achieving cost effectiveness. While could you share insights on the methodologies employed in comparing the cost effectiveness of KP interventions across different settings? May I hand over this one to Cindy to share?
Thank you, Kanye. Kanye is just putting me on the on the hot spot, on the hot seat for this one. What I can say as a country, we do wish to reach that level where we are modeling for different scenarios, looking at the different approaches that we're implementing as a country, so that we can establish the cost effectiveness of such. Which is something that we're looking forward to be supported by our partners as Ministry of Health. What I know we've done, it was modeling for PrEP, which we have also come up with different scenarios. But for the KP, we haven't. However, it is a part of our plan, because for us to advocate for the support, especially for the domestic financing, we need such things to engage our leadership, and for that support, especially when it comes to the KP program, where we still have challenge in terms of the domestic funding that we currently have. So we're looking forward to that, and we've also taken a cognizance of what you've shared there, Chris, that you are available for that. So we'll always remember you as a champion from Uganda when such tasks, maybe in the future when we have support, because it's also in our plan to conduct it. So we'll really consider when we're looking for people that can assist in that area. Thank you for availing yourself.
Thank you so much, colleagues. I think we have, I don't know if it's a hand from Thomas.
Sure.
Thomas, you have the floor.
Oh, thank you so much. I really want to appreciate you and your team for what you have shared. I appreciate the excellent work you have done, especially that as we are doing our demand creation activities, you considered both the structural barriers, the biomedical barriers, and the behavioral barriers. What I was curious to learn from you is, after using your IBBS and other documents to identify the situation, did you develop a demand generation strategy or an SBCC strategy, something that all partners can use and refer to often? Is there such a document?
Thank you for that question.
Yes, we do have a document that we've developed, the communication and advocacy, behavior change communication strategy that we've developed. Unfortunately, it was linked to a funding that was linked to PrEP. However, it is addressing the issues of KP within. Otherwise, we do have a communication strategy that we're using here for prevention. It's not only for PrEP, but it's all the package of prevention. So
Okay.
in short, yes, we did utilize that information to develop the communication strategy.
Great. It would be nice to share with us so that as we share what your work with others, we can also refer them to that document. I work for SSLN.
Oh, okay. No, thank you so much for that. I'm not seeing any more hands. I think we can move on to the last piece, which is sharing our key learning from this Link and Learn. I think I'll see by show of hands those who would want to share their key learnings from this. I think we'll start with Congo, then South Sudan, and lastly Uganda. Your key takeaways from this meeting. Colleagues from Congo.
Merci beaucoup. Bonjour à toutes et à tous. C'était une session vraiment riche. Par rapport à la situation actuelle du et de la cartographie, les données en cours d'actualisation. Et donc, ok, je peux couper la caméra. J'ai coupé la caméra. C'est bon? Ça s'est amélioré? Ah, ok, d'accord. Donc, c'était un peu la caméra qui rendait la connexion difficile. Donc, je disais ceci, nous sommes en plein processus IBBS. Donc, la cartographie est actuellement en cours. On est en train de finaliser le processus. C'est bon, vous m'entendez? Nous sommes en train de finaliser le processus de cartographie et ensuite, le mois prochain, nous allons commencer l'IBBS et l'estimation de la taille. Par rapport à tout ce qui vient d'être dit ici, je pense que, bon, il y a, si on essaie de voir au niveau du Congo, quand j'ai essayé de voir les partenaires qu'il y a à Eswatini, il y a notamment le PEPFAR. Or, nous, ici au Congo, on n'a que le Global Fund, on n'a que le Fonds mondial, ce qui fait que la mise en œuvre des activités ou des politiques nationales de lutte contre le sida connaissent des problèmes de financement. Il y a toujours des gaps financiers qui ne sont pas comblés jusqu'à la fin du cycle. Donc, on a déjà ce problème-là et nous espérons que le plaidoyer que nous sommes en train de faire à l'endroit du PEPFAR permettra à ce que nous puissions avoir aussi PEPFAR ici chez nous au Congo. Ce qui j'ai vraiment apprécié personnellement, c'est en ligne, les activités qui se font en ligne, parce que nous avons actuellement un gros challenge au niveau du pays, c'est pour atteindre les populations HSH qui sont d'un certain âge. Donc, ceux-là ne viennent pas dans des activités communautaires, il faut aller en ligne. Donc, pour nous, c'est vraiment cet aspect en ligne qui a été, qui est vraiment un aspect que nous sommes en train de chercher à développer de manière à ce qu'on puisse couvrir le gap des HSH qui ne viennent pas sur les sites de sensibilisation. Merci, je pense qu'il y a ça et s'il y a d'autres informations, on pourra toujours mettre à votre disposition. Merci.
Je suis Madame Medine de l'UAFPA. Je voudrais revenir, ce que j'ai retenu sur la formation que les groupes qui étaient formés, entre autres les agents de l'ordre ou bien les policiers. Chez nous, c'est ce que je voudrais dire là, chez nous, il y a aussi l'organisation de groupes, l'organisation de sensibilisation auprès des agents de l'ordre. Mais ce qui arrive que malgré les formations que les gens là suivent, mais ils ne respectent pas souvent, ils ne mettent pas en pratique ce qu'on leur apprend. Il y a toujours les violences auprès des professionnels de sexe, bien qu'il y a des programmes, il y a les moyens qui sont mis à leur disposition pour la sensibilisation sur les violences faites auprès des professionnels de sexe. En ce qui concerne le financement, comme mon collègue vient de dire là, JC, il vient de dire qu'il y a toujours les gaps. On ne parle pas seulement de gaps en termes des zones que le Fonds mondial finance, mais les gaps surtout sur le reste de l'étendue du pays. Il y a des zones où la prostitution se mène, mais il n'y a pas d'étude qui a été faite par faute de moyens. Et à chaque fois, quand vous voulez, par exemple, mobiliser les fonds quelque part, on vous dit, bon, par quelle hypothèse que vous affirmez le phénomène dans ces zones-là. Ça nous met toujours en difficulté pour mobiliser les fonds vu qu'on n'a pas d'études. Là, vraiment, avec peut-être l'arrivée des PEPFAR, on va voir, ou bien d'autres moyens, il faut qu'on voie comment mener aussi les études dans les zones où le Fonds mondial n'a pas mené les études et disposer des moyens pour mener les activités de prévention, pourquoi pas des prises en charge dans ces zones-là. Et voilà ce que j'allais ajouter sur ce que mon collègue m'a précédé.
Thank you so much for that. In the interest of time, may we move on to South Sudan? May you share your key learnings? Thank you.
Yeah, thank you so much. This is Moses Gala from South Sudan, a key population champion. Thank you so much, Eswatini team, for sharing with us the design and implementation of the business intervention, focusing on key population. Looking at South Sudan with a population of 13 million and the estimated number of people living with HIV is at 164,000, translating to 1.9. I just admire trying to look at Eswatini's progress with the 24.8% HIV prevalence, and looking at the progress towards meeting the units target, you're already at the 94, 97, and 96. And when I look at the South Sudan, we are still well below. I just like to ask so many questions. What is it that Eswatini is doing that South Sudan as a country could really adapt and try to look at? At the country level, we don't have national consensus data for key population. We really use estimates, and looking at the FR estimates, the female sex workers population in the country is estimated at 50,000, with the positivity, with the prevalence of around 12%. And 12% compared with 1.9% national population, that is high. So I really appreciate the method looking at the country implementation, looking at our country, our donors in the government, PEFA and Global Fund, like what is happening in Eswatini. And the government funding is very small. And that compromises really the funding to some of the strategies, business inclusive. And in terms of implementation, our implementation is structured in a way that Global Fund and also PEFA is aligned to states to regions that do the intervention. And all those are amalgamated to make sure that our interventions are structured to inform the national implementation data. So at our level, we don't have drop-in centers the way Eswatini is having. Our interventions are community-driven, and all those identified HIV positive are linked to the existing government facilities. And for key population in terms of subcategorization, what is being subcategorized in Eswatini as key population are the same groups that have been subcategorized in the Republic of South Sudan. But when it comes to implementation, because of the hostility of the environment, you find that the interventions are only targeting the female sex workers and their clients. Some of the subcategorizations of the KPs have been left out because of the environmental kind of hostilities, and that really affects some of the interventions. So at our level, I just like to reiterate that in terms of identification and training of the female sex workers, peer-led interventions, social network, training of health workers, advocacy, and making sure that the periodic kind of surveys are conducted, but the periodic kind of surveys are not conducted the way it is being designed after every 3 years. And I know maybe you have the funding, but the last one was conducted in 2018. How I wish we could have those kind of avenues to really have surveys conducted periodically after 3 years to really inform progress in terms of implementation. I also like the aspect of engagement of the CSOs to write implementation, like KP-led organizations for intervention. In the Republic of South Sudan, much as the implementation is now going towards engagement of civil society organizations, but it has not taken routine. It has not taken routines, but we have seen from you that the KP-led institutions are now at the front to make sure that interventions are cascaded. And now as we talk, we have the strategy of the Republic of South Sudan that was developed with support from Global Fund. And of course, it is already expired. But I look at the intervention that we need now to develop the new BCC strategy that now informs some of the new modalities of the online processes of demand creation that have been highlighted. So that it goes in the document, and then now it is rolled out to really make sure that we cascade the interventions moving forward in terms of progress. So I like the engagement of KP-led organizations, and that's one thing that with the support of the leadership here, I know South Sudan AIDS Commission is always on the forefront when it comes to advocacy, really deliberating and making sure that resources are mobilized, and much as resources are becoming full, but we need now interventions, we need to lobby so that at least we can revise, update, develop a new strategy that can now use to pull out the IBC materials that can be used to structure our intervention at the community to augment our BCC interventions within the country. Thank you so much.
Thank you so much, South Sudan, for your key takeaways. May we move on to Uganda? What are your key takeaways? I know we are over the stipulated time, but if you can briefly share, what are your key learnings before we close the session?
Thank you so much. Thank you so much. I'm cognizant of the time. We are of the hour by 4 minutes. This is Dr. Mjope from Uganda. Thank you so much for organizing this meeting, our colleagues from SSLN and Eswatini for accepting to take on the mantle, and my colleagues from Congo and South Sudan. This has been a very enriching discussion, sharing, and we are grateful. A few and many insights about the program population in Eswatini, which we note. Importantly, we note the high prevalence, which is not so different from Uganda, and also the incidence is almost similar to that of Uganda. there are quite a number of policy documents which you put in place, and we appreciate especially that the coordination and implementation structure, and also looking at the fact that key population programming is based by well-coordinated programs of all the partners. Government being key in terms of rationalizing the partners or the implementers, stakeholders on who implements where and on what program. We note that as a key takeaway. We also note that multi-sector approach strategy is key in addressing key population programming. The issues of stigma, reduction of human rights and violation and violence, and also community engagement are very key in engaging the different sectors, from the service providers, looking at stigma reduction in health facilities, but also looking at the law stakeholders who may arrest some of these populations because they engaged in behaviors that are considered illegal in the national laws. And the CS scores are very critical because the community, without the community, we cannot address the question of key populations. But we also notice that without addressing the question of key populations, we cannot end HIV in most of these countries. Specifically on the design of behavior interventions, I noticed quite a number of issues, but behavior interventions are really hard to design, and they require a lot of time and expertise from the different stakeholders, including the ministry, the community, and experts in communication. And lead organizations cannot do it, should be based on the needs of the population. That is very critical. There is also need for a mix. There's also need for a mix of approaches, both the online-based intervention and the paper-based IEC materials. In Uganda, we have not yet gone so much on the internet-based. I think this is an area we can learn from you more, because it is one of the strategies we have put forward for the Global Fund application, which we have started implementing this January, GC7. Coming to the last thing is that rationalization is very important by the ministry to allocate partners where to go, and there's need for joint planning with all the partners. We also note that behavior, the last one, is that behavior interventions and implementation are difficult to measure, and they require probably special tools and special surveys, maybe to understand the reach of these interventions and whether the message is clear or not clear, maybe to do surveys. But so far, waiting for IBBS, waiting for other surveys may not really be very efficient in real time to inform programming. I want to thank you and end here and say thank you so much. I just had to rush through the presentation because of time. Thank you, and over to you.
Thank you so much to everyone who has joined. May I request that we respond to the poll that is popping on our screens. May we kindly respond to that? Otherwise, thank you so much, colleagues. May I don't know if SSLN would want to say something before we close the session.
Nothing else from our side, but thank you so much, Khanyi, and thank you to the Eswatini team for this presentation, and thank you to all our country champions for participating.
Okay, so thank you so much to everyone who has joined us, and I hope we were all able to complete the feedback poll. And thank you so much. May you enjoy the rest of the day. Thank you. Goodbye.